We have another multimodality imaging conference for the heart system. And this morning, our speaker, our presenter would be, I would not try to say the last name, Patita, who is the Advanced Cardiac Imaging Fellow at Mount Sinai West. Also, we have a great panel, Dr. Kukar, who is the Associate Professor of Cardiology and the Director of Cardiovascular Imaging in Mount Sinai West. And thank you for coming in person, Nina. Dr. Steve Liao, everybody knows Steve. He's the Clinical Tract Cardiovascular Fellowship Director and also the Director of Nuclear Cardiology in the Mount Sinai Fuster Heart Hospital. Dr. Stelzer, Professor of CT Surgery. Thank you, Dr. Stelzer, for coming early this morning. I know surgeons are really dealing with early morning, so. And Dr. Tommy, I hope he will be here, who is Assistant Professor of Cardiology, and he's the Associate Director of the Cardiac Intensive Care Unit in Mount Sinai Fuster Hospital and Director of Cardiac Intensive Care Unit in Mount Sinai Morningside. Our moderator will be Dr. Handley and myself, and looking forward to this discussion.
Yes.
Thank you.
Thank you so much. Good morning, everybody. I would like to present an interesting case today. This case is 49 years old female, presented with dyspnea on exertions and shortness of breath for a month, denies any autonomy, PMD, or lower extremity edema, denies any further episode of palpitation or syncope. She has past medical history with essential hypertension, impaired fasting glucose, and obesity. She has no family history of sudden cardiac death, arrhythmia, or heart disease. On her physical examination, vital sign was normal, within normal limit, but her systolic blood pressure is quite good, well controlled in around 120 or for the every visit in her outpatient. She has a heart murmur with a systolic ejection murmur grade 3 of 6 at the left parasternal border and increased with Valsalva without radiation. Her PMI was not enlarged or displayed with LV hip, but no RV hip, otherwise is within normal limit. On her laboratory is no sign of anemia, a normal renal function test, normal liver function test as well. This is her first EKG, silent bradycardia with the LVH and localization. Her shed X-ray show like, oh sorry.
The left precordial leads, regularization is worrisome.
Sure, thank you.
No, I say that the left precordial leads, the regularization is worrisome.
On her shed X-ray, the heart size is borderline heart size, no sign of pneumonia, pulmonary edema, or pleural abnormalities. Okay, this is her echocardiograph.
Yes, Dr. Liao to take a look.
Yeah, so looks like there's some hypertrophy. Looks like maybe a little bit thicker in the septum, especially the basal septum. There is some mitral regurgitation. Perhaps there is some systolic anterior motion of the mitral leaflet there, some turbulence in the left ventricular outflow tract. Pericardial space looks okay. Left atrium may be a little bit big, a little bit hard to see here. Hyperdynamic or at least normal functioning of the LV, especially in the short axis. Aortic valve is frozen, but it looks like it has normal opening. So no evidence of aortic stenosis on that short axis view there. And I think maybe some asymmetric septal hypertrophy based upon the short axis, but overall looks kind of thick, would be consistent with their history of hypertension, perhaps.
Thank you.
4-chamber, 2-chamber. Again, a little clearer to see the systolic anterior motion of the mitral leaflet there. Normal function. I don't see evidence of apical aneurysm. Outflow tract, RV function looks okay. Yeah. 3-chamber, better view of that SAM, systolic anterior motion, mitral leaflet, a little bit of MR, not a whole lot. Some, again, turbulence in the LVOT there. The M mode may be suggestive of a little bit of SAM. Those resting gradients continuously through the LVOT, that shape of that continuous wave is suggestive of obstruction, since it's not the typical bell shape of MR. Looks more like a dagger. That's typically what we would see, and it starts a bit after onset of systole, and you can see that from the onset via the QRS complexes at the bottom there, and then pulse wave, I think, is up there on the top right. Hard to see where I'm sitting, exactly where that interrogation line is, but you'd also want to make sure that that interrogation line is where you would want it to be. So if it was mid-cavitary, you want to see exactly where that line was going through. If it was LVOT, you want to make sure it's going through, obviously, the LVOT.
Thank you. The MR is like ERO is just 0.1 is consistent with mine that you said.
Yep.
Yeah.
And then this is a stress echo with contrast. I don't see any evidence of wall motion that's provoked by exercise. I think that all looks like it contracts appropriate augmentation with exercise. Obviously, some of the views in systole on the panel on the left are obscured from artifact, but all seems to be okay.
I just add.
Yeah.
So if you just go back to the previous one, there's some important salient features. So if you look at the bottom left on the short axis, there are no distinct papillary muscles, but there's a lot of important cords. And when you see that, that's a hint that there's going to be aberrant cords to the mitral valve or to the septum, which is affecting contraction. If you look in the upper left, when you have an isolated basal septal hypertrophy, and it's sort of pointing into the cavity, just isolated at that point, you have to be concerned about an aberrant cord or papillary muscle, which is causing that tropism, which is going to lead to further focal obstruction at that level. If you look on the right side and you look at the upper left, again, you can see that aberrant papillary muscle, which is coming from the apex, so which makes the apex hypercontractile. So as Dr. Liao said, there's no distinct apical aneurysm, but there's apical hypercontractility because of that aberrant placement of the papillary muscle. So it's very important to analyze those things, because the aberrant papillary muscles or aberrant cords are very important, as we recognize now with echo and MRI, for the pathophysiology of hypertrophic cardiomyopathy and obstruction, which can be related not only to the septum, but obviously to these abnormal cords and papillary muscles.
I think that also has implications towards what the treatment might be. Abnormal cords that connect to the septum are not going to be treated with alcohol ablation.
So looking at the gradients post-contrast here, I mean, typically, I think if I were interested in the gradients, I would probably do those first before we give contrast. It kind of makes it a little bit more noisy and difficult to interpret here, but I think you would not be surprised if the gradient increased with exercise here, since there was those gradients that you detected at rest. So I think I could probably believe that. And then the pulmonary pressure, I'm not sure if I believe that tracing right there, but it would also not be surprising if it increased with exercise.
Thank you. And for a bit review about the gradient, typically in hypertrophic cardiomyopathy, the gradient is always slowly increased in the early systole and rapid abrupt in the mid to late systole too. So the characteristic of the gradients look like a dagger shape in the area of foot tract obstruction. Do you have any comment about the obstruction to provoke maneuver or something?
No, I mean, I think, the amyl nitrate, the dose isn't really standardized and stuff like that. So I think, from my perspective, the rest, Valsalva, that makes a lot of sense. And then exercise physiology makes the most sense in terms of provocative testing after Valsalva.
Thank you so much. And for the MR, typically you have to make sure that you get the signal from the true LV of foot tract gradient, because the the anatomy between MR and the RV outflow is quite close. So typically the MR velocity envelope look like start a bit early in the isovolumic contraction. Is tend to be longer and higher velocity. And so when we try to get the true RV alpha tract signal, we have to make sure that we not get the MR signal. Do you have any comment from the MR?
No, I think this is a very nice slide. It shows a lot of the different waveforms that you would see in continuous wave and trying to distinguish between them. I think the other one that you I don't remember if you put it on your slide, is the lobster claws of the mid-systolic kind of worsening. Also another sign that perhaps the outflow gradient has gotten quite bad.
Thank you so much.
So if I could just make one comment. Amyl nitrate, I don't think is used anymore at all. And I think what people use instead is other provocation. I remember Rick Nishimura, when he was here last year, was saying that around 35% of patients have a gradient at rest, additional 35% with provocation. That could be with Valsalva. And he said sometimes in Mayo Clinic, what they'll do is send the patient out for a Mexican meal, and then they come back and have obstruction. And the reason is that when you divert flow to the splanchnic circulation, you're intravascularly depleted, and the inflammation causes the gradient. So it's important to recognize that, again, only around 35% can have a resting gradient, but another 35% provocable. And that could be with Valsalva, we don't use amyl nitrate anymore, or with Psiam to a large meal, or with stress.
Try Chinese food next time.
I remember when I was at Mayo, it was a lot of obsession about hypertrophic cardiomyopathy. When I was at Mayo, it was an obsession about hypertrophic cardiomyopathy, Valsalva. I used to carry amyl nitrate in my pocket. Just to give you the sense of amyl nitrate at that time. I don't know what happened since, but I can tell you, at that time it was a big issue.
Most of the time at this hospital, we tend to stop the ladder at Valsalva. When is the right time to go ahead and do that stress echo?
I think if there's a suspicion, is like their short answer. I mean, it could be from the clinical side. It could be something that you notice on echo that perhaps you're not so confident that the echo tech is getting that appropriate, or perhaps if you're just getting to the point where you receive a report and you look at the images yourself and you're not sure. As you can see, I mean, just from that one slide over there, there's a lot of different pressures that you could be measuring, a lot of different velocities theoretically you're measuring. And depending on the echo tech, which is something that we all take for granted that our echo techs are able to find the appropriate gradient at the appropriate angle, these are all things that we assume and that we hope happen, but not always the case. So I think if there's any clinical suspicion of symptoms that could be from this, that perhaps you're not getting the gradient on the report, I think it would be appropriate to kind of continue testing.
Thank you. So this case we sent to MRI.
Thanks. So these are cine images of the MRI. So as you can see, for those not familiar kind of with MRI much, these cine images are essentially what you're able to kind of assess also based on echocardiography, where you can look at structure, thickness, and wall motion. And one of the particular things about cardiac MRI is your ability to really evaluate the apex for possible apical aneurysm that you may not catch as well on echocardiography, as well as focal thickness, particularly in the anterolateral wall. So as you can see on the top left, you see that basal septal hypertrophy, which is one of the more classic types of hypertrophic cardiomyopathy. Again, you see, I think it's just freezing a bit, but you can see systolic anterior motion of the mitral valve. In addition, you see this hypointensity in the LVOT, which is pre-valvular, which kind of correlates with what you saw in echocardiography with the pre-valvular turbulence, indicative of that dynamic obstruction. As you go down in the short axis views, you can see that there's focal basal septal, go back one slide, just focal basal septal hypertrophy. I think that got up to 1.6, if I'm not mistaken. Which again, greater than 1.5 is kind of more indicative of HOCM. In a family history, 1.3 would probably be raise suspicion as well. You can go to the next slide. And sorry, go ahead. Go back one slide one more time. can you just play the apical shots? And the next one. So this is interesting. It's not uncommon for hypertrophic cardiomyopathy to have several layers of obstruction, depending on the patient. And as you see, as you go down to the apex, you can see near systolic cavity obliteration towards the apex as well. So you have obstruction both at the level of SAM with the LVOT and at the apex. Okay, again, you have this nice 3-chamber shot where you really see this hypointensity in the LVOT, which is, again, indicative of that flow acceleration with SAM and the basal septal hypertrophy. You also see that probably what looks like visually maybe at least moderate posterior laterally directed MR, which again is that perpendicular angle to the dynamic obstruction, which is pretty typical for HOCM physiology. You can go on to the next slide.
This is just a short review about the hypertrophic cardiomyopathy. I think this, you know that well, is the most common genetic cardiovascular disease. And for the diagnosis, we just need to measure the LV wall thickness more than 15 millimeters in any segment in the LV. We have to rule out any hemodynamic pressure load to produce the hypertrophy, such as the aortic stenosis, hypertension. But if the patient has like a family history of hypertrophic in family history, we can cut down the cutoff to 13 millimeters. And this is a type of the hypertrophic in the echo. It depends on the shape of the basal septum and the location of the LV thickness. And in hypertrophic cardiomyopathy patient can have like an intrinsic mitral valve disease as well. For example, for the prolonged leaflet elongation or the anterior leaflet elongation as well. So when we see the MR in the hypertrophic, it's not only from the SAM, it can be from the intrinsic from the mitral valve that we have to be careful to look at it. As well in the papillary muscle as well, because around 25% of hypertrophic cardiomyopathy patients have an abnormal variant of the papillary muscles. For example, in the lower right-hand side, you can see that if the patient has like abnormal hypermobile bifid papillary muscle, that can cause the systolic anterior motion. And from the how to image the papillary muscle, we need the parasternal long axis in the echo and the short axis view to looking for the characteristic of the papillary muscle. And you want to, actually there is a lot of condition that can increase the LV thickness, and we have to try to differentiate. And one thing that can help us to differentiate, we don't need the T1 mapping to diagnose the hypertrophic cardiomyopathy, but T1 mapping can help you to differentiate from other conditions. For example, for the Fabry, that T1 mapping is quite a bit lower than these conditions. And in this case, patient has a hypertension, yes, but it cannot cause the LV thickness because it usually will in the blood pressure in the outpatient and in every visit is very well controlled. Systolic blood pressure is less than 120, no more than 125 in every visit. So hypertension in this case cannot cause the LV thickness. And how do you?
Let me just add one question there. We see thick hearts all the time on echo. When is the right time to send a thick heart for MRI? The panelists think.
Sure, I think that's a great question. Basically, if there's any family history, if there's been unexplained syncope, obviously I think any of the things we typically work up with HOCM and SVT on Holter. But MRI is now actually recognized as part of the testing that's routine for the workup of hypertrophic cardiomyopathy. It's not any suspicion, just based on echo where you then follow up with MRI. So I think MRI is a very reasonable test. If you see LVH disproportionate to what you're seeing on the blood pressure, that would explain it. Or athlete's heart, particularly if you see focal hypertrophy in one or two segments, that's asymmetric. I don't know if anyone else has.
This is a small comment. I think the point was raised that this patient's blood pressure was observed to be 125, and so that couldn't possibly explain thickening of the heart muscle. But I think although this is a conference on hypertrophic cardiomyopathy, it should be a little bit of a conference on hypertension too. is don't forget that there's a variation of white coat hypertension where blood pressure is normal or low in the office, but often high outside of the office. So before we write off the possibility of important hypertension, we should just be alert to blood pressure recordings outside of an office setting, whether obtained via fancy ambulatory blood pressure monitoring or simply home blood pressure cuff.
I agree. I think also, the benefits of cardiac MRI, even in the setting of hypertension where you suspect it, is also to evaluate for dangerous issues, like we mentioned, the apical aneurysm, focal septal thickness greater than 3, sometimes kind of better seen on cardiac MRI compared to echo.
I would just say if there's any discordant clinical data, I mean, it's something that we learned from rotating with Dr. Fuster is to look at the information primarily yourself, see what you think about the echo quality, images of the echo images yourself, look at the EKG if there's hypertrophy there and not on the echo, start thinking about why that could be, as Dr. Tommy said, blood pressure elevation or not elevated. Why is that discordant from the other information that you're seeing?
The second different comment that I would also make is that when we say if there's a relevant family history, then perhaps we're more inclined to pursue advanced imaging. Well, what does a family history mean? It doesn't mean the epic smart phrase for a progress note that pulls in the family history with none documented, etc. Strictly speaking, and what our guidelines endorse is really a thorough 3-generation family history. And so I think that if I were to see a thickened heart on an echocardiogram, it's incumbent upon me to really conduct that detailed 3-generation family history before I dismiss anything. And bearing in mind that the way in which a patient might report a history is not necessarily going to be my, sister's, mother's, uncle, etc. Had hypertrophic cardiomyopathy. It may be that, oh, this person died suddenly, but we never really knew the details. Or somebody had a big heart. Or, oh, they had heart failure. Well, maybe their heart failure was hypertrophic cardiomyopathy for all we know. So you have to be really inclusive in the manner that you ask the questions.
Can I raise a silly question? You talk about hypertension. What about the treatment of hypertension? ACE inhibitors and ARBs and diuretics can really fool you in a patient like that. Yes, your blood pressure is under great control, but you're hurting the patient with hypertrophic cardiomyopathy. So just help surgeons, of course.
Also, I would add that because hypertension is so common and a lot of these other conditions around are not so rare, one can have more than one. So that gets to be a little bit more problematic, trying to figure out how much one is different from the other.
What about separating from athlete's heart?
So I'd love the MRI opinion on that.
Sure. Well, the traditional teaching is to decondition those patients, which obviously no one likes to do when you're an athlete, unless you're me. That's very easy to do. But there are features on cardiac MRIs such as T1 mapping that have been, at least in the research world, kind of look very promising in being able to differentiate athlete's heart versus hypertrophic cardiomyopathy. So that's one possible feature. Again, once you get up to a thickness greater than 1.5, that's more suggestive of HOCM. Significant disproportionate septal hypertrophy or focal hypertrophy in any 1 or 2 segments, also more suggestive versus something more concentric.
I was just going to add, typically athletes' hearts are more dilated, so I think that you should raise your suspicion that the LV chamber is not particularly large.
Dr. Stern's point about inclusivity of multiple diagnoses, I think, is critical. Another paradigm where this becomes relevant is as we work up patients who are preparing to have a transcatheter aortic valve replacement, where a subset will have asymmetric thickening in the subvalvular apparatus, and questions arise as to what to expect in terms of dynamic left ventricular outflow tract obstruction after relieving the valvular lesion. And the question becomes, are these individuals who have concomitant hypertrophic obstructive cardiomyopathy and aortic valve disease? Or is there some instigating factor of a pressure overload state that actually accelerates a process of myocyte disarray, hypertrophy, or even perhaps hypercontractility? And a point from a pathophysiologic standpoint that I think is pertinent is that to this day, there's still much mystery shrouded in, why there happens to be a genesis or an acceleration of thickening or hypercontractility of myocardium at one or diffusely points to the certainly, as we'll talk about some of the novel pharmacotherapies that are addressing more biological mechanisms of hypertrophic cardiomyopathy, this becomes very fascinating and interesting. But somebody with hypertension, for all we know, management of hypertension over a lifespan perhaps is relevant to later onset in life development of patterns of hypertrophy that might mediate obstruction. And perhaps even the degree of pressure overload that comes with aortic stenosis is one of a multi-hit hypothesis that brings about that asymmetric thickening later in life. And so perhaps there's some marriage between managing blood pressure over the lifespan and the perpetuation of hypertrophy and pathologic patterns. And I think much needs to be learned about that.
Okay, was there a question? Hey, Dr.
Just getting back to the athlete's heart, we all group athletes into one big, I guess, grouping. But if you looked at Jack over the last year, there's been at least
Gina,
12
just hold on, because
publications.
people who are on Zoom can't hear, unless you use the mic. Thank you.
I don't think we could group athletes into one big grouping. And Dr. Fuster in his publication, and Jack, there's been at least 12 publications of the athlete's heart in the last 12 months. And one in particular that stood out for me was a beautiful chart that broke down the type of sport and how the heart changes depending upon that sport. So a long-distance runner would be very much different than someone who is a professional weightlifter going to the Olympics versus someone that's rowing and would have a combination of both dilated heart and hypertrophy. So I think grouping it into the athlete's heart, I think we have to be a little bit more specific sometimes and looking at, obviously, going back to the patient. Also, MRI is fantastic for that because sometimes echo with these patients have LVH and RVH if they are an athlete. And sometimes on echo, we take in the RV septum and include that into the LV wall thickness. So MRI is perfect for that.
Thank you. One more.
Can I?
Yes.
I think that we all use the 15 millimeters, but I think we need to start to get away from the 15 millimeter and the 13 with family history. 15 for a tiny white woman is not like 15 for a black man. And the British group actually came up with a calculator where you put the maximal wall thickness and you put the age and the gender, and they show you how it is on the, the percentile. They don't include yet race, but they're actually working on it. So I think you look at other things like multiple papillary heads, abnormal valvular apparatus, LGE, and the asymmetric. So the 15, I think, I'm not using it anymore, to be honest. I think that MRI is extremely helpful because of that also. So my threshold to proceed with an MRI is extremely low, especially if you see thick heart in a young person. Of course, I think you should proceed with an MRI. Whereas it's a 75-year-old with hypertension, then your, clinical suspicion is lower than, but we all know also that the yield of genetic testing and clinical and family history in young people with HCM is much higher than older people, and we even think that there might be a non-genetic, non-familial hypertrophic cardiomyopathy at older age. So it might not be exactly the same disease, kind of like it goes along with what you said. And I think that it's probably a different, not just phenotype, but it's a different disease probably. Last thing that I wanted to say is that family history, a lot of the time people will tell you, yeah, my uncle died of a heart attack. They think it was a heart attack, but if you actually ask them, they just presume it was, that's what people told them, and it was actually sudden death and no one really bothered to do autopsy. So always be cautious with the family history and ask, how do you know that it was a heart attack? How do you actually, was he known to have, did he have bypass before? And you'll see that a lot of the time it's not really MI, but actually sudden death. So
Thank you, thank you.
Thank you so much.
Dr. Kugar, can you take us through the LGE and the
Sure.
tissue characterization?
I'll just show, it's okay. Thanks. So this is the late gadolinium enhancement imaging. So as you look for nulled myocardium, which essentially is where the myocardium looks black, just for simplistic purposes. And you're looking for essentially areas of enhancement, which here I believe you can see, I don't know how well it's projecting, very minimal kind of enhancement in the basal septum, which is a characteristically mid-myocardial pattern versus, subendocardial pattern, which would imply more coronary artery disease. Mid-myocardial pattern has a very broad differential. Obviously, in this clinical context, we're not going to tell you the patient has sarcoidosis. This is clearly minimal enhancement in the setting of a variant of hypertrophic cardiomyopathy. Crucially, obviously, as everyone knows, the guidelines now recommend, if the late gadolinium enhancement is more than 15% of the LV segments, that is a higher risk of sudden cardiac death, and ICD is recommended. So this is actually a very important part of the cardiac MRI to really be able to accurately describe the percentage of enhancement. In this case, obviously, I don't think this patient meets criteria. To the person's point in the back, sorry, I don't know your name. But definitely agree that obviously it's also a very dynamic process, and the guidelines also recommend that patients get repeat cardiac MRIs in 3 to 5 years if there's clinical suspicion, as this can change with time. I believe this patient actually had a CMR in 2017, and this was from 2022, which would be appropriate, again, in the right clinical context where you suspect that things might change.
Tita, would you mind showing that slide that shows scar quantification since we're talking about it?
Right, so on the top left, obviously, we do this visually, where we work on the 17 segment model again, that everyone is familiar with, and we go based on the wall thickness, 1 to 25, 25 to 50, and so forth and so on. And based on that, we get a percentage of mass that is affected. There are more advanced technologies that we don't have. I don't know if Dr. LaRocca has access to. That actually are more automated, and that will probably come out with time as more routine, with AI kind of being able to accurately quantify scar size and not just rely on the visual assessment.
Yeah, circle imaging has that. We don't use it because it's not FDA approved to give a percent of late gadolinium enhancement or scar tissue. Once there becomes standardization with the new ACC AHA SCMR guidelines coming out in 2025, that will be standardized, hopefully. Fingers crossed.
Thank you so much. Let's get back to our case. After we do the echo and MRI, and we try to maximize the beta blocker, the patient still has symptoms. And the echo, after maximize the medication, the IV gradient is still like 60 with the Warsaw maneuver. So what should we do next for this case? Do you have any comment?
So there are 2020 ACC/AHA guidelines, and then there are newer guidances from the European Society of Cardiology, who in general have been quite prolific with their elaboration of guidelines. But as this slide is alluding to here, there are emerging some options that use different mechanisms, we can say, to address the pathophysiology and symptomatology of hypertrophic obstructive cardiomyopathy, and then present an interesting question about where they may fall in a step-ladder of interventions, in which conventionally we previously had beta-adrenergic blockade and calcium antagonism, and then septal reduction therapies. I'm sure you're going to devote some slides to the myosin inhibitors, mavacamten, and some of the newer ones. And I don't want to steal thunder, but I think it's an interesting conversation we can have now about where we might incorporate these agents prior to septal reduction therapies, whether there are patients that we might preferentially select to go to a septal reduction therapy before even attempting something like a mavacamten, And I think we'll hopefully talk about some of the pragmatic challenges of executing mavacamten therapy, which I think have compromised the widespread use.
I think this is the right time, and we'd love to hear your thoughts. Do you think we're moving to a time where everybody gets a trial of mavacamten before we do something invasive? How's this going to go?
I think that there's great promise for the class, noting that beyond mavacamten, there's a next agent coming down the pipeline, aficamten, that has an advantage of having a shorter half-life of elimination, such that we'll have an opportunity to ascertain its effects and maleffects on the heart more quickly, without some of the protracted surveillance of echoes that becomes required for mavacamten. And if anybody here has attempted to prescribe and manage mavacamten, number one, in order to do so, you need to go through a semi-rigorous approval process, a so-called REMS process, to be able to prescribe and manage it. But then the patients need to have echocardiograms essentially every 4 weeks from the point of initiating it. Never minding the inconvenience for the patient, think about the conversations with the insurance companies about the every 4-week echocardiogram authorizations. And then there are very specific pharmacies that they're exclusively able to use that they themselves have passed tests in order to prescribe this. So it's a nuisance of a drug. But with that said, the data from trials that have explored it, no pun intended, have been very promising in demonstrating a significant reduction in not only the overt obstruction to left ventricular outflow, but also even to some of the degrees of myocyte disarray when pathology has been studied later out. So I fall short of saying that we're ready for prime time to say that everybody should get mavacamten first, because that there are many very human and individual considerations that need to go into the practicality of doing it. But I have certain optimism that in the future that a sizable number of patients that historically we would have committed to invasive septal reduction therapies, as perhaps the VALOR HCM study shows, can be spared the necessity of undergoing an intervention with significant reduction in their outflow tract obstruction.
I just want to say, Dr. Rabinowitz and I are participating in a study with the heart failure group in Dr. Croft's lab looking at echoes in patients that are receiving mavacamten. I don't know, we are blinded to what dose and all that sort of thing, but we basically have 2 or 3 patients that Dr. Rabinowitz and I split reading their echoes pretty frequently, and from what I've anecdotally seen, it's very challenging to get consistent measurements even in the same patient with the same echotech across a fairly short period of time. Anecdotally, we've both seen the numbers go up, down, and all over the place. So all this to say that obviously there needs to be statistics and everything else in the study in order to show a significant difference between the groups, but just I would interrogate the study with caution, I would say, when it comes to kind of using at least these parameters of gradients for assessing for success of the drug.
I think you have to use echo contrast. You can't make accurate measurements without echo contrast. That helps a lot. And actually, the drug's a wonder drug in that patients have relief of symptoms.
That's different.
Way,
That's
way
different.
Before you see a change in septal thickness, you see the gradient go down because it's a negative inotropic agent, extraordinarily strong negative inotropic agent, and that's the whole reason that you're monitoring that. But from a clinical point of view, you need to use contrast because otherwise you're not going to get accurate measurements of wall thickness. Secondly, you frequently can overestimate septum because you're looking at RV trabeculation or moderator band. So having contrast is crucial, but it usually takes 6 to 8 weeks before you'll see a response. So if patients think that it's immediate, like surgery or septal alcohol ablation, it takes time, and usually going into the second dose level before you're going to see a symptomatic improvement. But when they have it, it's a change in their life. It's dramatic. It's like Entresto in heart failure.
So one question, however. These are drop of ejection fraction, 10% in 7% of the patients thus far at 1 year of follow-up. Just to mention that this is not a free, just for everybody. In common sense tells you that ejection fraction can be affected by the drug that is affecting the contractile function.
What about exercise? Do you know, I mean, I know you do provocation with the Valsava for these patients, but what about during exercise? What happens to the gradients? I mean,
So the REMS protocol doesn't include exercise, and that's the issue. I've had 70-something patients on mavacamten, and the issue is that the REMS protocol only requires Valsalva and rest, and if it's lower, then you need to lower the dose. And you know that the symptoms, the patients are still symptomatic, for example, but the gradient is not high. So what I used to do is either I would tell them to have a heavy meal half an hour before and then squat and stand several times in the echo lab, and then you'll get the gradient higher. And if not, I would just do a stress echo, which is a challenge with the insurance a lot of the time. But unfortunately, that's the caveat with the REMS protocol, because it's only, and that's how you basically need to determine, they allow you whether you can increase the dose or even decrease. But from 73 patients, I've had one that still ended up having a surgery and one that her MR actually got worse because the stem actually resolved, but then she had intrinsic mitral valve. But otherwise, the 71, it's been like a miracle to have people basically, it's wonderful, but it's a very, I think the protocol, the REMS has issues with the stress for sure. Aficamten, I think, will make our life much easier, to be honest, much easier. I still have some patients, by the way, that want to stay on Norpace or disopyramide. They're happy on it, they love it. If they have side effects, they're also on Mestinon, and they're perfectly, and I try to convince them, but they are like, no, I love it. Why would I change? So that's also one option that I think it's still there. You know, just don't forget about it.
okay.
Thank you so much. So this case, do you think we should use mavacamten or not for this one?
Okay.
You're like mavacamten for this case?
I mean, I think if the stars align, I think it's worth a trial.
Okay. So, patients still have a symptom. So the next step is to therapies, septal reduction therapies, which we have two options now: is the surgical myectomy or the alcohol septal ablation. Do you think which one does work for this one, for this case? Do you have any comment?
I'd love to hear Dr. Stelzer's perspective on septal ablation versus myectomy.
Well, it's certainly, in the old days, all we had was this surgical, and that it's kind of a tried and true thing, but it is something that's certainly experience dependent, to be able to do it safely and not have complications. That can be done. It's a hard operation to teach because you can't really have more than one person seeing down that hole, but it can be done. So I think that's still the gold standard. It also deals with those anomalies in the outflow tract. We're more sensitive to concomitant mitral valve disease at this hospital than most hospitals, and I think that's important. I mean, if you've got a primary posterior leaflet prolapse, that's not going to get fixed by doing a septal myectomy or give alcohol, either one. So you do have to look at that a little bit more carefully than the Mayo folks would say that everybody can be treated with just a septal myectomy. That's not necessarily true. So we want to really look at that heart very carefully. And I can't agree more with Dr. Dawkins that you got to look at the pictures yourself to know exactly what you're looking at. And you know, alcohol ablation does work. It's a little bit more of a sort of a shotgun approach to the septum. You're not sure exactly what's going to die when you hit that thing. Is it going to eliminate the part that you really want, where the surgical is obviously a very focused removal of the obstruction? The only problem with it is that there's a tendency to not take enough out. And I can't remember a case that I didn't think I could have taken more. It's just amazing how scary it gets when you start going deeper and thicker and more extensively from one side to the other. And you don't want to make a VSD. I even ended up outside the heart one time. That was scary. But it's not met without complications. So there is a limit to how far you can go. And the echo is really important to be able to identify who's going to be the good candidate for this. Not just how thick it is in one measurement. You got to know how is that distributed. When you look from trigone to trigone in the muscular part, where is the thickest part? Is it consistently thick? Is it all in the area right underneath the membranous septum where we don't want to cut because of the conduction system? Or is it, you know, in the nice place right underneath the right-left commissure where we can make a great deep tunnel, go as far as you want, and have a very good result? So the distribution of that, and looking for those anomalous connections, those funny chords are sometimes very hard to see. But the echo is getting much more precise in being able to tell us about those things. The TEE is helpful as well sometimes. But just suspicions when you see that prominent bulge right below there and then comes right down and you see the anterior papillary muscle kind of leaning over toward that. Just imagine there's a line between those two things and you need to cut that. You need to take that off. And sometimes the anterior papillary muscle is just kind of plastered against the septum. And that's very easy to mobilize that all the way down to the base of the papillary muscle so that you really eliminate. Where does the SAM actually start? It starts right at the tip of the papillary muscle where the cords start. If I don't get down below that, I may leave something. So that it's all about how you do the operation too, not just, oh, we'll do it surgery instead of alcohol ablation. It's what kind of surgery? How's that being done? So it's not just a black and white thing.
Can you predict before the surgery how good the surgery will be? By
Can we
imaging?
predict?
Yes.
I'd like to say yes. I think the thicker the septum, the more likely we are to relieve the problem. And the less mitral disease or fixable mitral disease that we see, you know, if we've got a big posterior leaflet that's pushing things anteriorly, we can make that smaller, pull it down, and make sure that that goes backwards. Some people take out part of the long anterior leaflet. There are all sorts of things we can do to help minimize SAM. And that's more important, especially if you have a really high angle, the aortomitral angle, for instance. All those geometric considerations have to be looked at before you say we're done here. So yeah, you can make predictions, and the worse it is, the better the chances are you can fix it.
So unlike a MitraClip or some of the other interventional procedures we do, you can't do intraoperative guidance with echo, right? Because there's no blood in the heart. So do you use transesophageal echo beforehand though to answer some of these questions that maybe we didn't answer on our initial TT?
Well, you guys are pretty good at answering most of those things on the preoperative studies. We confirm all that with that, absolutely. Look at that transesophageal echo very carefully so we know exactly what we're up against. You know, any asymmetries in that. I say, how far below the aortic valve does it start? How far does it go? How thick is it? Where is the thickest part? Am I sure I'm going to get that? If there's a great deal of asymmetry, I need to know that. And I also, you know, just how thick and where it starts and where it finishes, those are probably the most important things that I can ascertain from the intraoperative TEE. Because that's my target then, to take out that stuff.
Yeah, thank you, Dr. Stelzer. There's new technologies coming out with electrocautery. There's that Sesame procedure that they're using catheters and kind of these electrocautery kind of lassos to kind of scrape away at the septum. What are your thoughts on these kind of new procedures using kind of catheters to try to do septal reduction?
Well, I guess it's sort of the difference between a green light prostatectomy and a real prostatectomy. You can make it better, I think. It's just a little bit tougher to make sure that sucker's in the right place. And you're not going to hurt something that you don't want to hurt. like the mitral valve, like the subchordal apparatus. You know, if you're gonna take out some of the major chords and end up with a flailed leaflet, that's not gonna be very nice. So it's very tempting, and they're getting better and better at being able to know exactly where they are. I mean,
These are very well selected patients from China. They have done 20 at this moment. The results are outstanding, but they are very selected patients.
Yeah.
Very significant obstruction and nothing else in the mitral valve. If you look at the patients specifically.
Yeah, it has to be extremely well selected. That's exactly right, Dr. Fuster.
Thank you so much for the comment. And this is just a quick review about the imaging guide in surgical myectomy that you said the TE intraop is very helpful to identify the location of the maximum thickness and measure the maximum thickness for the surgeon and evaluate the mitral valve and area for tract gradient. And for the post-op, we have to look at the complication from the surgical myectomy. Do you have any comment more about the imaging, about the surgical part? It's okay. And for the alcohol septal ablation as well, both pan-thoracic and TE can help a lot to identify exactly that when you choose the septal ablation, that this is the appropriate septal branch that we have to use it after we inject the ultrasound enhancing agent and look at the septum that is a correct area that we need to. And nowadays we have like a TE 3D with a NPR multi-planar reconstruction that can help to make sure that the area of the ablation is the good location to choose the ablation.
So yeah, I'll just finish it. So we don't use TE here. Dr. Kinney does these in the cath lab, and we usually echo guide her using obviously echo contrast to try to find the correct septal perforator. We tend to do these in older patients that are really not candidates for surgery. Now that we have catheters around, maybe we're going to do less, but we basically find the septal perforator that we think has touches the septum where we want to reduce it. She'll inject the contrast and we'll echo guide her and see where it is. The biggest problem with this is we tend to try to balance how much alcohol we give versus how much heart block we cause, because we try to pick a septal that doesn't go through the septum where the pathway goes. So sometimes we'll do a little and then send the patient home and then see where the gradient ends up. And we don't, right away, the gradient will go down and then it returns and then they have to wait for the septum to die and then the gradient will go back down. So sometimes we'll bring these patients in 2 or 3 times so we don't put them into heart block. We're lucky sometimes if they have a pacemaker, then we can be more aggressive with them. But Dr. Kinney's gotten great results, not always, but right away when we inject the alcohol, the septum will be stunned and then the gradient will go down and the MR will decrease. But like I said, it's a fine balance between giving enough alcohol to kill the septum because we can't see what Dr. Seltzer sees versus coming back and forth getting a complete heart block.
As a small reaction to that, I think one of the things that always fascinated me is how they report the seemingly instantaneous improvements in the laboratory in these cases. But that's a testament to the fact that hypercontractility is an important biological aspect of the disease process. So it's really the stunning of the hypercontractility that mediates the immediate effect, whereas the necrosis is the longer-term durable effect.
So the other one more comment to make from what Dr. Tommy said earlier regarding aortic stenosis and focal hypertrophic cardiomyopathy. So many times now we do alcohol ablation on patients who have severe AS and hypertrophy of basically the basal septum. And the reason for that is that when you have thickness hypertrophy of the basal septum, there is a risk of embolization when you deploy the valve to the aorta. So many times today we do, like somebody who has severe AS and hypertrophy of the basal septum, we do first alcohol ablation of the basal septum, and then a month later, when the obstruction is relieved, then we go ahead and do the TAVI. So that's something that we do today, yes.
This slide is real good in demonstration of that would be a bad place to put a TAVR. Because the obstruction happens, the hypertrophy happens immediately below the valve. Yeah. And you need to have a little landing zone for your TAVR. Exactly. And that's a little hard to do in this situation.
Thank you so much. For our case, we decided to do the surgical myectomy. And after the surgery, with the echo, the wall thickness had gone down from 2.3 to 1.6. I'm sorry for the slides, not move. And the MR is decreased. I'm sorry. And the gradient with Varsawa decreased from 79 to 36. And patient feel much better after that, but still have occasional shortness of breath, deny any autonomy, PND, and leg edema. And as I said, echo from post-op echo show that the LV gradient is down to 36. And on her note in physical examination, we didn't hear any murmur anymore. And the EKG post-op had shown like a normal sinus rhythm with the lepidem band block post surgical myectomy. That's been common, right? After the surgery.
Let me just comment that I know when Ismail did this, he measured the pressures, as many people do, directly in the left ventricle and the aorta, simultaneous pressures, and there was a 2 millimeter difference. I think that there is some degree of, I'll call it selection bias in terms of which red cells you're following in terms of how fast they're going. And we always measure the fastest red cell coming through. I see that a lot in RV outflow tracks after Ross's, and they tell me that the gradient across that pulmonary homograph is 70, and the peak right ventricular systolic pressure is only 60. I said, now, how can that be? It just can't be. And if you cath the patient, the echo is just overestimating. And I think it's the tunnel effect of those things, and this is a tunnel that's going through. It's not just a discrete obstruction, like aortic stenosis tends to be a little bit more discrete, so I think we're a little bit more accurate when we're looking at a stenotic aortic valve in terms of how much really pressure gradient have you got. When you're looking at a longer course of it, like you are in HOCM, it's a little bit different. So I think when all else fails, listen to the patient. If the patient is really feeling great doing the things that she wants to do or he wants to do, you've probably got to win.
How do you like to follow these patients with imaging post-operatively, and do you ever see recurrence of obstruction?
Well, I haven't had to redo anybody that I've done, but I've seen it redo. Several of the people that I've done had one before. But so yeah, and even this, you look at that gradient, you say, gee, it's only down to 1.6. It's still hypertrophy. You're not down to normal thickness. Sure wish I'd have taken a few millimeters off of that. And that brings the question too that I have for you echo guys. I like to say the whole thickness all the way through to the right ventricle counts. I don't make a VSD unless I go through it all. So if you just tell me you're only going to measure the left ventricular septum, like you can separate those on MRI very nicely, yeah, I'd like to just kind of stand at that. But technically, all I have to do is not make a VSD. What do you say about that? What's your standard? You measure the whole thing, or just?
I mean, I think that on echo, it sometimes can be difficult, especially with the moderator band and trying to distinguish RV hypertrophy, which sometimes can happen, from LV hypertrophy. Sometimes you can see it pretty clearly on echo as well. It's not always the case. But MRI, I think, is probably the most helpful. I think from my perspective, I would go with the LV. If we can get that measurement accurately, the LV thickness.
The LVOT usually doesn't recur unless they didn't really do deep enough myectomy, so meaning they didn't really take enough muscle to begin with. Only in children, we've had a few cases where children had myectomies at a very young age, and then they needed another myectomy when they were older. Usually after myectomy, you see a gradient of 1 digit, to be honest. After alcohol septal ablation, around 30 is kind of like what you see. You don't really you still have residual obstruction, but with myectomy, usually you don't really see it. But some of the patients remain symptomatic because they have diastolic dysfunction, or they have very small cavity. So we do have these patients that end up even having transplant after successful myectomy, unfortunately.
I think with surgery, you'll see later on that some of the hypertrophy continues to regress because some of the secondary hypertrophy, which wasn't the genetic abnormal tissue, but the hypertrophy due to the outflow obstruction, just like with aortic stenosis, will regress. Whereas in septal alcohol ablation, because of the stunning, you may get recurrence of the gradient. So the surgery, if it's done, like you were saying, where you fillet appropriately, you get a much more durable outcome than you would with septal alcohol ablation. Do you want to mention about the issue about pacemakers? Here we have a left bundle branch block and the incident to pacemakers with septal alcohol ablation versus surgery.
I think that the incidence is pretty low unless you've had an alcohol ablation first and it failed. And then I tell the patient you're almost always going to get a pacemaker because the septal ablation causes right bundle branch block. And if I do a good job, I get a left bundle branch block. I think you have a slide that shows the percentage of left bundle branch block is less than 50%. I get it almost 100% of the time. And I think it's a function of how much you take out. If you're really doing a very thorough septal myectomy surgically, you're going to get a left bundle branch block. And so, you know, you're smiling back there. I think you're right. I just don't think I've done a good job. And there is, technically, there's a little bit of an advantage to that dyskinesia that you get with that, just like we used to think we could treat hypertrophic myopathy by putting a pacemaker in it and making sure you get RV, and you get that pacemaker kinesia, I used to call it, and it didn't do very much, but the left bundle does have some of that effect, as you know.
When we do the alcohol septal ablation, if we're very aggressive, they'll go into heart block. We always put a pacemaker beforehand, and that's kind of our stopping point. We're watching to see if the conduction comes back. And then we'll try a little more, but then inevitably we stop when they start being paced.
Yeah. And the other place where I think, you know, you mentioned children, a lot of children who have a subaortic membrane have the membrane taken out, but either it's incompletely taken out or they don't take any muscle with it. And I'll grant you, it's a little trickier in taking muscle out of a little kid, but those are the ones that I've had to redo when they get to be 25 or 30 years old. Now their aortic valve is trashed, and so we're doing a Ross and subaortic obstruction removal at the same time.
Maybe I missed it, Matthew, but mavacamten was considered here, or I missed the case? Why, and it was not considered, why?
Maybe you can say something that I couldn't tell from the slides whether or not it was offered
3 years ago is when the patient
I
presented,
see.
so.
Understand. Thank you.
But I'm curious, actually. So we're in this interesting transitional period where mavacamten is now becoming more available. And of course, Valor HCM looked at the use of mavacamten to avoid the need for septal reduction. But for those patients who might have had a septal reduction therapy that was perhaps less than desired or less than effective, is there a role for mavacamten and the like as a second-line treatment for those who perhaps have had an initial operation, have some residual or recurrent obstruction, to spare them reoperation in the case of a prior septal reduction therapy? For example, would you rather take somebody back to an operating room or give them a trial at this time of something like a mavacamten?
Interestingly, mavacamten is beginning to be used in patients with hypertrophic cardiomyopathy without obstruction. And the thinking is that diastolic function may improve. There is a trial going on that.
I think reoperation is always lower. I'm always surprised at the patients, doctors who are more eager for me to redo an aortic valve instead of do it in the first place. Wait a minute, you know, don't be in such a big hurry to go do reoperations. That's a lot bigger deal. So I tried that. I think that the other 800-pound gorilla in the room is the cost of that drug. And I remember I was looking at one of Vivek Reddy's talks over on playing on YouTube, and the number that hit me was that over 50% of patients at 1 year quit taking the NOACs because they were too expensive. And that's a huge problem with this drug. It's so blooming expensive that it's not a sustainable thing. I wish I could talk to the insurance companies and say, you know, if half of your people quit taking the drug after a year, but they should be on it for life, how about if you cut the cost down to tenfold less, and you're gonna get 10 times as many people on long-term therapy? Surely it doesn't cost you that much to make the stuff. This actually makes sense in the long term for you guys. Maybe we can convince the drug companies that it would be to their advantage to lower the cost. I don't know, that just seems like maybe that's the way you have to approach it. There's so much into the bottom line this quarter kind of thing, like all of America is in the business world. They've got to think a little bit more long term, and that would be the benefit to them and the patients we're trying to take care of. You're still fighting over the drugs that lower cholesterol, right? I thought that was going to be a miracle drug. You're right, it is, but we can't get it for people. Not the number of people. Surely more people need that than need mavacamten. We haven't done that yet. How many years have you been working on it?
PCSK9 inhibitors, the cost came down. I think the only language they speak is money, so
That's
once
right,
they
that's right.
realize
So
it,
make it cost effective for them.
but I'm not the world's
Any
expert on
closing,
this.
comments, Dr. Dunn? Any closing comments?
You know, this case was chosen in part because of the growing excitement around this disease at the Fuster Heart Hospital. So if you have any thoughts, Dr. Tommy, on the work you're doing in your group?
So I think a testament to Dr. Fuster and his vision, Amy Kontorovich, who's, I don't believe is here today, has done really so much to grow a Center for Inherited Cardiovascular Diseases here at Mount Sinai. And really, Amy is such a leader of this effort here at Mount Sinai. It's been a privilege to be a teammate of Amy and Dr. Fuster's and some of the work that they're doing. But I think that what we're appreciating here, thanks to Dr. Fuster's leadership, thanks to Dr. Bott's leadership coming on, is that there's been just an amassing of talent here at Mount Sinai. And it's such a critical mass now that I think that there's nothing that should stand in the way of Mount Sinai becoming really a genuine international leader in hypertrophic cardiomyopathy, much in the way that it's an international leader in so many other domains of cardiovascular medicine. And so it's just a very exciting time, I think, for everybody to be here at Mount Sinai. And for the fellows, I think, you know, what an embarrassment of riches of people to work with here. If you have interest and excitement of hypertrophic cardiomyopathy, this is a great time to be at Mount Sinai.
Thanks so much, and thank you to all of our panelists. You can grab some of these credits.